This episode of The Dental Guys is brought to you by the Dental Crafters Network, your implant restorative connection. From surgical planning to patient-specific guides, quality implants, and final restorations, the Dental Crafters Network provides one relationship with infinite possibilities. Call 1-800-472-8302 today. That's 1-800-472-8302. You're listening to The Dental Guys, episode 54. I'm not impressed with your impressions. In this episode, we're in Geek Corner all night long, baby. We discuss the current state of the quality of crown impressions in dentistry, and also an interesting article about how long you can wait to put crowns on root canal treated teeth. Spoiler alert, you have 4 months until your tooth explodes. For more on that, and also an updated Product of the Week segment on retraction techniques for digital impressioning, sit with the nerds at the cafeteria lunch table today on The Dental Guys. Welcome to this week's episode of The Dental Guys. I'm John, the Dental Guy.
And I'm Wes, the Dental Guy. And John?
Wes, man, I'll tell you, we've been talking about this episode for a little while since we read a couple articles.
A couple of really great articles. I have read these twice now, all the way through, and took notes on it for the show tonight.
I noticed your notes, man. They're epic.
And, man, there's just some great stuff today. I can't wait for this episode. But, John, more importantly, but a little bit about the Dental Guys. You may have noticed a little refresh of the logo, a little refresh of the music, the intro. If you're tuning in live on Facebook, you may see some new colors. We've went away from the brown, and now we're into something a little more eye-catching, something a little newer, and we're excited about that. And a little shout-out to Always Abounding.
Yep.
And
did a great job on the design.
They're doing a great job. Ryan and Caleb over there, shout-out to you guys. They do edit the show for us and handle all the back end as far as these things go. So we appreciate all the work that they're doing behind the scenes for the Dental Guys. I'm excited about the Voices of Dentistry conference. Voices of Dentistry, man, it's going to be great.
It's going to be a great year for it. You know, we've been talking to you guys about it for the last couple of months, but it's really now starting to get some steam behind it. We're starting to hear a little bit more about some of the people that will be there at this event, including Jamison Spencer, who's a big name in sleep medicine, dental sleep medicine. He'll be there talking. And I got to talk to him a little bit at the ADA meeting this last couple of weeks ago. And he's excited about getting to be out there. And of course, lots of people at that conference that are doing some dental sleep medicine stuff like we are. And so that's going to be great. A lot of other big names. And so if you are still on the fence about this, it's time to get committed because we're running low on spots. They're starting to fill up. And we really want to get you out to Scottsdale to get to meet us as well as some of your other favorite dental podcasting groups, such as the Dental Hacks. We're going to have Mark Costas out there. We're going to have all the people that you probably have on your playlist. Most importantly, us, of course. Natural. You know,
T-Bone speaks.
T-Bone's going to be out there.
You know, we're going to put him back on our show again. You know we will.
Got to.
And there's going to be some controversy around some topic we're going to discuss with him. But it's going to be a good conference. I'm excited about it. I mean, like we have listeners that are telling me they're coming and they're excited. We have people that haven't been that listen to our show and they're excited.
Yeah.
So 16 hours of continuing education for the weekend. And what a greater place to go. Scottsdale, Arizona. There's not really any better place in the wintertime than maybe the beach. But listen, Doubletree Resort, Hilton Hotel there in Scottsdale. John, let's see. Is it?
And also, too, there's just one other thing there that there is a coupon code.
Oh, wow. What do we got
available?
Now?
And I don't know if it, well, you know what, Wes? I think it's expired.
Yeah, I think that the last one,
that's right. That was through last week.
Yeah, I think that's over. But hey, listen, spots are filling up. If you missed out,
worth it.
Just go ahead and sign up now. We want you guys to come there and support the Dental Guys and maybe get on a show. Maybe we can get on. Maybe we can get you on our show. We're gonna be
Yeah,
live
you're
streaming
really good.
from Scottsdale, so it'll be really good. So, John, what about these articles that we've been talking about here? Where did this come out? Like the one article for the endo came out of nowhere, and you found it, and you sent over some stuff on it. Tell me a little bit about that before we say goodbye to the live stream. Maybe give a little tease about what we're talking about.
Yeah, well, I was doing some research on post-success long-term. I was just talking with another friend who was wanting to know what I thought about the success rate of post-treated teeth. And so I was just doing some geeking out on PubMed, looking at success rates of posts, and I just must have entered in a certain combination of text with success and posts. And this article came up that was relatively recent in one of the endo journals, talking about the Journal of Endodontics from 2016, talking about, and the title of it, we'll just go ahead and tease it with the title, an 8-year retrospective study of the critical time lapse between root canal completion and crown placement, its influence on the survival of endodontically treated teeth. So we've talked about the importance of the coronal seal, and we talked about that in our endo series.
So what is more important, coronal seal or good root canal? And let me ask you this, John. The answers in this article is when, like, here's the case. Right now, this time of year, people are trying to get in to optimize their insurance benefits. And they want to do a root canal this year and put your core in it, and maybe they don't have enough money to put the core in it, and you say, well, we'll just do the core and crown next year. Like, what does this article tell us is really interesting? And I want to thank everybody that's been joining the live stream, because we do have a few watchers out there. So if you're joining the live stream, we're going to say goodbye to you. And
thanks, guys.
Thanks, guys,
girls.
for joining us. Yes, and dental gals and dental girls.
Yeah, so that got me thinking. You just asked the question there as we finished up the live stream. What is more important, coronal seal or the quality of the root canal? And like you say in this article, it really changed things for me in my understanding, because we knew there was a problem. I mean, don't you tell patients, hey, if we're going to commit to this, you got a root canal, you need a crown.
Yeah.
And you tell them that, and then they say, well, what if I wait? How long can I wait? How long can I wait to get the crown?
You can't wait. And that's what we're going to find out here is, and I think this is something that you and I talked about back in endo episodes, is coronal seal so important. And we said that our favorite day is the Monday you walk in after the weekend, and it's endo, core, and crown all in one visit.
Yeah.
And there's a reason why John and I try to get our patients, and pretty successfully, John. I would say we were talking about this when this article came out in our office, and I said, what percentage of the time are we not doing the crown when we do endo? And they were like, hardly ever. They said 90% of the time we're doing the crown and getting it done. And you might say, man, the barrier's insurance. Don't make insurance the barrier, and here's why. But let's have a little background, John, on this article and some of the things that were mentioned in it. Periapical health depends more on the restoration than on the endodontic treatment. We know this. There's been other articles that say that coronal coverage is as important as high-quality endo, and those have been documented really thoroughly back in 95 and by some other clinicians. And it's interesting that we know that teeth that aren't crowned, that are endoed or root canaled, are 6 times more likely to fail, according to one study. And clinicians debate about this all the time, because there is one article or one research study that showed that there was no significant difference in the survival of those teeth that were treated than that are restored with amalgam, composite, or cast crowns.
And I struggle with that.
That was from 80. That was back in the 80s.
87. And that, that came out of UConn, came out of my alma mater, and it was done by, Langeland was a big name guy at that time back in the 80s. And Kamran Safavi's the lead author on that. He was the head of the endo department at UConn when I was there. And, I don't know. Like, I look at what Aquilino did in JPD 2002, which was the other article that showed 6 times higher failure rate. And I tend to think that I don't know. I read the Safavi study. They did have they were both retrospective. So that's not quite as strong, as prospective. But I think Aquilino's study made a much stronger case for that teeth that were endodontically treated that didn't have crown were more likely to be lost than what Safavi did, because their paper was a little bit more limited, in my opinion, in terms of number and follow-up. And too, the technology, that was 1987 versus 2002.
Yeah.
If anything, that should have gotten better. You know what I mean? Like, if in 87, if there was no difference, well, then we should even have even better.
Well, you got 2 studies.
It seems like it's getting worse.
2 studies that are more recent that proved that one wrong. And I think that the interesting thing about this study is that it does something that no other study has done. There's no clinical study that has investigated this effect of when should we restore, and does the restoration time lapse, meaning the time between endo and final coronal seal, does it affect the outcome or the long-term predictability of endodontically treated teeth? And that's what this study did. Now, the interesting thing is how big the study size is.
Oh, yeah.
It's huge.
This is awesome.
Like, we're talking about looking at teeth over an 8-year period of time. They looked at 1,373 teeth, and John, that yielded, after they went through an exclusion criteria, which was really good, actually, by the way. That yielded 882 teeth. So they looked at 800 teeth, roughly, almost 900. Only posterior teeth. All these teeth either received full coverage crown, composite or amalgam buildups, or a temporary within a 24-month time period. There was no crack noted during root canal therapy, and the outcome of the endo was acceptable. So they showed that with preoperative and postoperative radiographs after the endo, that everything was acceptable. This was an ideal situation as far as the root canal goes. It wasn't anything crazy, and then they looked at the results.
Yeah, and I think it was about as good as you can do with such a huge sample size. I don't think I've ever seen anything quite that exhaustive. And when they looked at this, when they were comparing, what was cool about this, I thought one of the coolest things about it is that they had the temp in there, as like a good control, because the temporary should tell us, in theory, if the study is going to be good, that it should tell us that the temps don't last, because if the coronal seal is really as important as we are talking about, then these teeth with temporary restoration should be failing at a pretty high rate over that long of a period of time. And it was kind of crazy how much failure they had. They said teeth that did not receive a permanent restoration after root canal showed a survival rate of only 58%.
Yeah, 27% never received a restoration. And they also mentioned in the conclusion that there needs to be better communication to the patient, because this is kind of sad, is that if we had 800 and 900 teeth, let's just say 1,000, and 270 of those patients that had a root canal never got the crown, that was money they spent. And I know life happens, but that's 25%, 27% of people that are sitting in your chair never get the crown. Now you say, well, it's not my fault, but are we communicating with the patient? Are we communicating to the patient the necessity of the coronal restoration? I think it's something that we get busy and we forget these things, and I think it's important that our team realizes it. I told my team this study. They were like, well, that makes total sense. And that's one of the reasons why you've always said we need to go ahead and scrap out not doing temporaries. And I think it's they mentioned too, a failure. If you're not doing endo in your office and you're having an endodontist do it, how quickly are you getting them back to your office? I know that whenever endo is done in another office, my front office team, which knows nothing about procedural other than this, when they see the email come in that the root canal was completed, they're calling the patient.
Yep.
And I don't know how many times, this happened early on in my systems of learning how to run a business, as that patients don't call. And it's like, well, whose fault is it? Is it the patient's fault, or is it the doctor's fault? Listen, patients are not responsible enough to know. They think, well, I can just wait till my cleaning to come in and we'll talk about it then because I got this temporary. Or maybe the endodontist in some cases went ahead and did the buildup. And did that help? Because this study shows some interesting things about just doing buildups, like the success. And so if you figure, well, today is, November, and a person goes to the endodontist and they have a root canal done, and they go ahead and put the buildup in there, and they say, well, I'm not due for my cleaning for 5 months. They do that because they show up in your hygiene chair, and whose fault is it? Is it our communication? That's one of the things that the study talked about, is that we don't communicate properly maybe with our specialists, and that's why there were 27 people, or 27%.
That never got a permit. And 58% of those were extracted.
Right.
So you
high
have to
failure
figure,
rate.
you're basically dooming your patient to extraction by not making this a priority. So that's one thing you learn from it. And, then the next thing, Wes, is you start to talk about what is the difference between placing a crown and doing a direct restoration. That was interesting. And then maybe more interesting to me, and I think this is something that we just kind of both, as we were reading this, kind of really occurred to us, because there's a very interesting graph that was, and we'll send this if you guys want, to see this study. Of course, we'll
put it up on our website.
Yeah, it'll be on the website in the show notes. And it's just, there was very interesting graphs showing what happened at different time intervals.
Oh yeah.
And man,
they call it the hazard ratio.
Yeah, hazard ratio of loss. And they showed this very interesting time interval.
It's bad.
They found that these teeth that had, even if they had the crown several months later, like if you got the crown from 4 to 6 months, and then they looked at these teeth out further, they found
24
that
months.
They found that there was this increase in failures at like 2 years plus. So what's going on with that? Well, what I took from that is that there was leakage that went on during the time this patient was in the temporary for too long, compromised the seal. Then these teeth got a crown. And then even later, there was this uptick in loss, like where the problem showed up later after this. So basically what they said was that if you put a crown on 4 months.
After 4 months.
After 4 months, you were 3 times likely to extract that tooth over 8 years.
Here's the thing, is that, and the times likely that that's going to happen, at 18 to 24 months, it's 10 times more likely to happen that you're going to extract it. Meaning, like, if you wait 2 years to put a crown on somebody's root canal tooth, like, at some point you have to draw the line and just say, let's just take the tooth out.
Right. Because you start to say, at what point should we not even maybe put the crown on?
Okay, so I had this patient
worried
come in
about
the other.
that.
I had this patient. She's 75. Okay,
Mm-hmm.
she has tooth 17, and she has tooth 19. She had 18 extracted
Mm-hmm.
when she was probably, I would say, 13 or 14, and then 17 drifted in whenever that came in, and she had 17 root canaled and cored. Okay. And she's 75. She's been in my practice for probably more than 10 years.
Mm-hmm.
And I was redoing some work. Actually, I was doing a root canal on tooth 19, and that had a crown on it, that had a, because of that drifting, you know, what happens is you get a food impaction there, and with dry mouth, that marginal leakage happens at the distal root. So I ended up doing a root canal on 19.
Mm-hmm.
So here I am after reading this study, and I'm thinking, man, should I even touch 17? It's been there like 30 years.
Yeah. Good
And
question.
And the answer is no, I shouldn't touch it, because it doesn't improve its survivability at this point, right, John?
I mean, it seems to indicate here that
if
you look at the overall probability of the survival of endodontically treated teeth, according to the study, it says remained relatively constant for teeth that received a crown from 4 months up to 18 months after the root canal. However, at 18 months, the ratio of tooth loss experienced a sudden rise. And what they say is one suggested explanation is that sudden increase could be that the time interval represents the time for a clinical presentation or occurrence of most crown or root fractures. So it could be that they see this jump up because that's how long it typically takes a tooth to fracture. But the question is, like you said, these long-term teeth that have not had a crown,
like, what do you do now?
if they're asymptomatic and they haven't had a problem, I tend to take from that the coronal seal is probably still intact.
So what about these teeth like premolars? These teeth. What about premolars, man? Like you see them setting there and you're just like, oh man, implant magnet. And you wonder, okay, this has most likely not an MOD. It's most likely just a root canal from an occlusal that for whatever reason got deep. And it's on like a 60-year-old and it's been root canaled for 30 years. Do you touch it?
That's a great question. You know, I think if it doesn't involve a marginal ridge,
you probably
debatable.
shouldn't touch it.
I always think if it's my
outline,
tooth,
it's an outline risk at this point. So
Yeah.
it's an inform the patient, hey, look, I don't think
this
we need
could
it.
become a problem.
This could become a problem. If we touch it, it could be an issue. It's not an ideal situation. They're like, well, what's ideal? Well, if you would have had it crowned within 4 months and you haven't had any issues with it and you're not having issues now, we took a cone beam and it looks great, then don't touch it, right?
Yeah, I mean,
what do you
it's
think,
tough.
man? It's a tough call.
It's tough because I got from this the question is, you know, does this paper show that the problem is that the coronal seal is falling apart on a lot of these teeth after 4 months? Or is what it's saying is, hey, if you have a tooth that's asymptomatic, cone beam looks good, and it's been 30 years, you go ahead and put a crown on it because your coronal seal is still intact.
And I know
I think the jury's out on that. I think to me,
that's a tougher call.
Yeah, I think what we can say for sure is that if you are the one that's involved with the treatment of this tooth at the time, like right now, you know, that you got to tell a patient, listen, you know, you've got a window of time where this is most successful. And if you get the crown within 4 months, studies show that your risk of losing that tooth goes down by 6 times.
Yeah.
6 times. Now, if you go out plus 4 months, there you are, up 6 times more likely to lose the tooth. And that may not happen until you're 18 months in, because now that's where root fractures happen, or it may happen earlier. But you got to be aware that the difference in these results was tremendous after 4 months. I mean, it really surprised me. I think it changes. I think it gives us a little bit more ability to cite science on this, because we always knew it was important, but I've never seen a time frame on it until this study.
That's the first one. I think the study even cites that, is that they have not found, or doesn't seem to be a clinical study that existed that did this, the effect of time on endodontically treated teeth. So if you're out there listening to this, I guess really the practice pearl, the take-home message is what John said, is that people that have teeth, posterior teeth, that have been endoed, they need to be crowned, not just built up, within 4 months of having the root canal completed. So really, you're in trouble if you don't. And I think that the question then is the gray area is okay, so the patient does have life happen. You did the build up, you sent them home, and 5 months rolls around. And so that you're not backing into the conversation, the patient sits in your chair and you say, what do you do, John? Do you go ahead and crown it, or do you say, hey, look, I'm a little concerned about this now?
Yeah, I think that's
and it's
what
informed
changes.
consent, and you just
I think
put
that's
it in
what it changes. Yeah, you just have to be willing to say, hey, it's been a few months. I don't see any clinical evidence of a problem with the tooth, but I just want you to know that there's some science to show that your risk goes up after 4 months. And maybe that's just because more of those teeth start to fracture and you haven't had a fracture, so you're good. But we're really not sure if that means that the coronal seal is breaking down more after 4 or 5 months. And maybe that's the problem. And if that's what we're seeing here, you may have a higher problem needing to retreat this root canal.
This study also took into account occlusion. They took into account arch form, all those things. And they took into account post. They did use post. These teeth that were posted were fiber post. So they were, passive fit post. That didn't affect the outcome, however, the fact that the post was done. So I think you just have to have these conversations now that you have a little science that has been repeated recently with a lot of teeth. I mean, this is a big study, so 882 teeth inside the study. And to me, I'm going to be using it every year, every month, when I talk to my patients about root canal therapy and crowns.
Yeah, and to your team too.
The team is the key. The team is the key.
That's a really great study to share with your team and say, guys, this is why it's so important. And when the patient calls and they say, I want to wait till my next cleaning, then, hopefully they remember, well, that's right. The doctor said that, if you wait longer than about 4 months, there's a much higher risk of you losing this tooth. And they're telling the absolute truth based on the best science that we've got. So, but, I think that study was, was encouraging. This next article is not.
Yeah, this is bad.
This is bad.
Well, let's just go a little. Let's go ahead and enter this. I mean, this is really embarrassing, guys, that we aren't doing better. We're doing worse. We're doing worse. What is it you do and make money with? You make crowns. You do fillings. Crown and bridge. We're not everybody, practices specialized. Most people are doing crowns and fillings in our practice. And the average dentist, I looked up some statistics, John, in a most recent November article from JADA this month in November's, I found that we average 18 crowns per month, and the healthcare cost associated with this is $20 billion a year. The average remake rate in the United States is between 2 and 4%. The thing that's interesting about remakes is that you look at remakes and it's most likely due to the crown not fitting properly because of rocks on the prep or marginal integrity, but it's a pretty low remake rate. But John, what are we sending to our dental labs? We're sending.
Man, I mean, this study. If you haven't seen this study, the quality of fixed prosthodontic impressions is the title of it. I mean, it's a very bold title. I mean, it's the first thing I thought about this when I read it. It was like, this is making it sound like the definitive paper on this, and it is. I mean,
It
if
is
you
kind
look-
of is because in 97 there was one. In 95 there was one.
right.
2005 there was an article, and then this one in 2016.
Yeah, and this is Terry
17.
Donovan. You know, he's no joke. You know, he's the director basically of materials and at UNC, and it's also done by Ritter, who's the chairman of the operative department, restorative department at UNC. So you're basically getting authoritative information here on what is the current state of the quality of impressions that are received at commercial laboratories. And let's first go through just what did they do? You know, they did it right. First of all, they visited labs over a 12-month period. So they didn't just go look at stuff that students were doing. You know, they went to labs over a 12-month period in 2013 and 14. 3 were large labs, 1 was small lab, and they sat and evaluated. I mean, I love dental educators, man. They're just awesome. They sat and evaluated impressions basically all day on the days they visited, excluded impressions for veneers or resin bonded partials, implant abutments, and they just looked at crowns. And they calibrated each other by inspecting impressions rejected by the student clinics as being unacceptable. So they all agreed on, you know, what errors were good, what errors were bad, and then they evaluated the impressions using 2.5 mag loops under room magnification. So this is actually using less magnification than what most labs would use.
Yeah, I think Brad, the dental lab guy, uses microscopes.
I think it's 8 or 10x on these, or 10 or 12 or something that they use. Yeah. And so they noted for each impression, type of tray, type of prosthetic, what the errors were, and they just reported on the results. And that's where it goes from being good to being really, really horrible.
Really bad.
I mean, Wes, let's go through it with us a little bit. I mean, how first of all, maybe before that, you mentioned those other studies that were done before. Okay. So what did they find in these studies that let's go back to the studies that we saw back in the 90s that you cited. What were the error rates or defect rates in those?
Well, 97, 290 impressions were evaluated across 4 dental labs. 38% had defects. 2 years later, 50% had defects in 99. In 2005, 193 impressions were evaluated from 11 labs. Get this, 89% had 1 appreciable error. So what about this one? This study that we're talking about today that was released this year in the Journal of American Dental Association evaluated 1,157 impressions.
Yeah.
It took them a year.
It's definitive, man.
Yes, this is a definitive study, a wake-up study, you know, and I just talked to...
So this is not. Yeah. This is getting worse, right?
And actually, it's worse, okay? So,
because some people might think, okay, these old studies, they only evaluated 200 impressions. Now, that's a lot.
That's a lot.
But you know what? You could have seen, you know, maybe they had their worst 10 people send impressions, and they just happened to have a lot of impressions from those worst 10 people, and they saw, you know, 70 bad impressions from like 4 guys or something. So you might think, well, maybe that just wasn't enough, or you didn't read the study and find out that they randomized it. But 1,157 impressions, I think we can all agree, over a year, this is not some little study that just didn't have a high enough power. So Wes, what was the percentage of these 1,157 impressions that had at least 1 error?
It's embarrassing. 86% of the impressions had at least 1 error. Okay, now you might think, well, what's an error? Well, of the errors, okay, let's just list them off here. and talk a little bit about what this means. Of the 86% that had errors, let's just say 900 of the 1,157 impressions had errors. 450, 49% had the error of tissue over the finish line.
50-50.
50%.
You're a lab tech. 50% of the impressions you get have tissue over the finish line. You don't know where the margin is.
So what do you do? If you're trimming this die, okay, and we talked about repetition and die trimming earlier on in our podcast, and how that I have a Pendex. I try to sell it, but nobody wants to buy it. But you would think that the repetition of trimming your own dies, let me just tell you what it did for me. It took my tissue retraction to the next level.
Sure.
You get rid of the Expasil, people. Get rid of the one cord technique. Get rid of the impression material that comes into your offices and says the no cord impression material. Listen, it's out there, and people are trying to sell it to you, and look what it's doing to our dentistry. 49% had tissue over the finish line. That means the margin integrity is terrible. We had a listener text us and say, hey, I'm going to dental school because the people that I work for are telling their patients that crowns only last 5 to 7 years. Now, why are they saying that? Well, they're saying that because, one, they know that they just want to go in and get it done, and they don't want to worry about it. But number two, they're wanting to cash in, to my opinion. I'm going to call them out. You're wanting to cash in on the fact that insurance is going to pay for your crown every 5 to 7 years.
Yeah.
And
so
that's
if you
fraud.
make it suck, then you just get to do another one in 5 years.
What's Jenny?
Make another
What's
$1,000.
Susie Q going to say when you walk in? Say, hey, you're not brushing your teeth, and they aren't flossing, and you got dry mouth, you got a cavity, and it's like, oh man, I just had that crown done 5 years ago. Well, no worries, your insurance covers half anyway. We're going to redo it. They pay for it every 5 years, and everybody's happy.
Well, but I think the thing that the other error that they cited here was that 55% of the errors were critical errors.
Critical, right? Yeah, 86% had some errr.
Right. But I mean, some of these errors were things like, some of these
critical.
errors were, lack of unprepared stops and a dual arch impression. Now, that's not good, but it doesn't mean your crown won't work. You just might have more adjustments.
Right.
Or pressure of the tray on the soft tissue. Well, you could have distortion.
Right.
But these are things where you couldn't look at the impression and say for sure whether the crown's bad.
Yeah,
55% of the time you can say, reject this impression. It's not good. We can't use it. We cannot use it because we cannot see where the margin needs to go.
And what do they say whenever they're at the lab and Brad, the dental lab guy, is taking high quality images, and he's saying, doctor, can you show me where the margin is? And they say, just make it work. And yes, that goes on. And it's like, what? Just make it work. I don't understand it. It's interesting to me. There's an article this month in JADA in November of 2017, if you're listening to this in the future. In November of 2017, there was an article. John, I put it in the Dropbox. Yep. It talks about evaluating impressions. And they sent out to doctors, general dentists, a few specialists, and they sent out and they got surveys back. 1,700 dentists surveyed, okay? And what they looked at was they said, okay, here's 4 pictures of an impression.
Mm-hmm.
And they wanted you to basically score or reject, basically evaluate. And they did it in a way that was acceptable. And the interesting thing is that it showed that, hold on just a second here, let me give you the exact results, is that it was kind of scary because if there are errors, should we not be, as dentists, recognizing them? It says, although dentists were largely consistent in their evaluation of impressions, greater than 85%, Non-clinical factors were associated with whether an impression was accepted. Lower crown remake rates were associated with more experienced clinicians, optical impressions, and not using dual arch trays. It also showed that most dentists reported a remake rate of less than 2%, whereas some report a remake of greater than 4%. Now, if our impressions, 50%, 55% of them have critical errors, and the lab is just making the crown because the dentist just says make the crown, and we're only sending back 2 to 4%.
Yeah, that's the thing. I'm looking at this going, okay, so the average lab remake rate's 2 to 4%, and we have 55% critical errors. So
what's the problem?
Well, I mean, what that means, Wes, is that there's two problems. The number one problem is that the dentists are sending crap impressions. That's, of course, the number one problem.
So you think they're cheaping out on their materials, or they're just not handling it properly?
No, it's not materials. I can tell you right now, I did a test a few years ago, okay? And
I know what you're go because
I did a test a few years ago with a really cheap VPS.
There you go.
Okay, I'm not even going to say what it was, but it was really cheap. And and then I compared it to a really nice VPS on crowns, single crowns.
Yeah,
there was no difference.
No, it's all made in the same factory for the most part. It's all about how you use it.
I'm not saying that there aren't certain advantages in certain difficult situations.
We're talking single unit crown and bridge, John.
Right. But maybe a tough crown prep, subgingival. There's some materials we know the chemistry's better. That's why I use nice stuff. I don't use the cheap stuff. Okay. So I tried it, but then I went back to what I was using. But the point is, the materials, I could give somebody Patterson brand VPS, who's a good dentist. They're going to get a great impression.
Yeah, of a single unit prep, no problems.
No problem. And even, dude, I could even give somebody a full arch, and they probably could still, if they cared about tissue, retraction, and they cared about
it's the number one error. Tissue
proper
of the finish
time
line.
in the mouth with the impression, let things set, proper syringe time, respect. Just follow the freaking rules, man. All the rules you learned in your first couple of weeks in your fixed preclinical education, you just follow those same rules. Now, when you first learned those rules, you weren't very fast, but you got the job done, right? Because you knew you had to trim that die. You knew that if you sucked at it, first of all, they wouldn't let it pass.
Well,
let's just say you had a joker.
Guess what the study said about die trimmers?
Oh, yeah.
People that wanted their die trimmed in this study, they had better impressions.
They had better impressions. Well, and it's not a huge surprise. You think in school, again, we knew we were going to have to trim our dies, and we knew somebody was going to be looking at them. So we had to be good because we knew somebody was looking at them. Now, what I want to know is, first of all, what happened? What happened to dentistry?
Well, good dentistry is a moral issue, John. I'm not the only one to say it.
Yeah.
Good dentistry is a moral issue, and I guess the morals of society have went away.
But I also have to say this, okay? So,
I can't.
We love our labs, okay? We love our lab.
I know. I know what you're getting ready to say.
But I have to say this too. Labs are not asking enough of their dentists.
No, they're not.
And I felt more and more, and where I'm coming from.
I know where you're coming from.
Not just our personal experiences, but we've talked about this a lot. I sometimes hear from labs, they'll say, oh, these dentists, and then, but they're not asking anymore. Their employees. I hear this interesting thing, when I call and I say, what do you think about this? And it's like crickets on the other line, man.
Well,
crickets.
it's like today I heard about a situation where, how do I even talk about this without, I don't know that it's hard to talk about something.
Yeah, you don't want to like call anybody out here, because
here's the thing,
the
is
reason
like
we work with the labs we work with is that we found people who will care.
Okay, so here's the thing, is like,
But,
drop your
man, it's
ego, drop your doctor for a second,
Mm-hmm.
and listen to somebody that trims more dies than you ever will in your entire career and looks at more margins and stacks more porcelain. I have learned so much from dental lab technicians. They are an integral part of my team. They can teach you tissue retraction. They know what good impression material will do for your hands. They can come and teach you. And you say, well, they don't have the doctor. I don't care.
Right.
They put on their pants just like you put on your pants and your shirt, and you drop the doctor attitude. I mean, I'm ranting a little bit, John, but this is the problem, is the egos of the doctors.
Egos are a big problem.
It's a big problem.
But I think our dental lab technician friends out there, you need to feel comfortable. You need to get, let me put it this way, you need to get better.
Well, here's the thing, John. Why don't they just say no? Why don't they just say no?
but you need to get better at, I think, defining what a good impression is.
I think you're right.
I think there's a problem somewhat in educating doctors as to, well, what are you looking for?
Right. Well, it says that in here.
Tell your doctor what you're looking for. What is it that, like, if you have a problem, tell the doctor what you're looking for, and then show them what a good impression looks like and how do they accomplish that. Don't be afraid to say, hey, I'm noticing that we seem to be having this trend of problems where you're sending crowns back, or you're having issues with margins, and I'm not seeing margins as clearly as I'd like. Let's talk about this. Is this a material problem, or is this a technique problem? Let me share with you.
Has things been busy? Are you, I mean, yeah, let me show you how to do this, and here's what I'm looking for. Evaluating, learning how to evaluate your impression, learning how to detect these errors. That was one of the things that they mentioned in the article, was that we need to learn how to detect errors in our impressions, and just throwing without any loops on and just looking at it is not good enough. And you need to put your loops on. You need to look at this under light. You need to clean the blood off. That was interesting about the study. They showed where blood, that's disgusting. There should be no blood sent to the lab. That is a contamination nightmare. They talked about that, how it's embarrassing. Yeah. And they saw a lot of blood. I don't know what the solution. I asked my wife, I said, what's the solution?
It's not going to get solved.
Is it not? I mean, what you're saying, John, is you're saying it's not going to get any better. Now, let me just tell you something about impression material. I want to drop back here and talk about materials for a minute, because you're exactly right. Listen, my dentist in my hometown took, with a really good irreversible hydrocolloid alginate, crown and bridge impressions. And he poured them up, and I looked at his crowns, and they fit amazing. But he used high quality. Do you remember reversible hydrocolloids?
Sure.
Like, it was forever. It was the hallmark.
Yep.
The hallmark of good crown and bridge impressions. And think about the margins back then, how good the gold margins were.
Yeah, but this is why I don't think.
So it's all about technique and material, learning how to handle these materials. They said that there was one out of all these impressions, that the material didn't even homogenize or polymerize or whatever you want to say.
Yeah.
And that's interesting, is that somebody sent it to the lab and it wasn't even set. It didn't set.
I just, I think that what it's maybe sounds cynical, but we go to these courses, right? And you always have people, when they go to a Crown and Bridge course, when they go to Gordon Christensen's course, that's just an example, because there's not a whole lot of people just talking about regular old day-to-day, how to take an impression Crown and Bridge.
No.
What do people want to know from Gordon? What's the most common question? What impression material should I use? What retraction material should I use? Material. It has nothing to do with it.
Yeah, and it's all about technique, John.
It has 1%. It's 1%, 5%, maybe 10% of the whole deal on a tough case. Yes, your material can make or break you. I'm not saying these materials are not important, but stop that crap. Come on. You think that's what's going on. You know that's not what's going on. Anybody that really, if you really search your heart and you go, is the reason why we're having this problem because of a bad materials? Come on, man. The materials were great in the 70s, man. Like you said, Wes, the materials were already amazing in the 70s, and we had no technology. So don't tell me that. The only thing that materials science should have done for you is to make the really tough ones a little bit easier and to make things faster. But instead, what's going on is it's just a lack of technique. Nobody even cares anymore about their technique. They don't care. They don't care. And so I know we talk about this, and the people, unfortunately, that I think have listened to our show are the people who care. Thank you for caring.
Thank you for caring.
Because we are, unfortunately, we and another percentage of the dental world are the only people that dentistry has to count on. Not Wes and I or something, but like guys or girls listening to the show.
Care. Guys that want
We're the only thing that's going to make dentistry successful in 20 years, because if it's 89%, 86% of impressions are bad, 89% in 2005, I mean, everything's getting worse. That's a good measure of how bad dentistry is right now. It goes back to what Wes and I often say, which is only about 5% of dentists that actually care. That's about right.
That's about right. In any industry, really, in any industry, it's sad. But listen, you want to crush it?
Yeah.
You want to crush it? You care. You care about it.
Take a little extra time and do it right, and you will sleep better at night. And I promise that this is, again, it all comes back, and we got to get off this topic, I know, but why are so many podcasts, Wes, about business?
Well, I
can't get enough new patients. Mm-hmm. I can't get enough new patients. I'm not busy enough. I'm not making enough money.
Listen.
And this is what we're seeing in the trenches is half your impressions a lab can't even make a crown on. So your dentistry sucks. And now you spend 99% of your time listening to business stuff. And you don't want to go anywhere for CE, and you don't want to read journals, and you don't want to, but then you want to complain about your business.
But John, I have got $400,000 in debt. I've got to figure out a way to get out of debt. And you know what? You will get out of debt.
Yeah,
you will get out of debt. Do it right.
Just what if doctors, what if MDs were like this? What if MDs were, just for a moment, just think about this. Like, what if MDs were like, well, 50% of my heart surgeries, people die, but I'm really cranking them out faster than I ever could. Obviously that would never fly. It's kind of a joke. I mean, no one else operates like this in the healthcare world that I know of, except maybe other kind of quackery type of stuff.
Listen, it's
no one else that takes it seriously. Pharmacists can't be 50% wrong. No. MDs can't be 50% wrong. So why do we think this is acceptable? Why do we just keep going on knowing, and we know it's wrong. It's not like it's like, oh, I didn't know that. You know your impression sucks, man. So get better. We're trying to help with that. Keep listening to what we're doing. We're not perfect. We have all struggled with these issues because it's business versus clinical. There's a struggle. But like Wes said, it's a moral and ethical decision. Every single day you get up, you go in, you get that first impression out of the mouth that you know is not good. You're already 45 minutes behind. Take it again.
Right.
Just make the decision.
The relationship, the article says, the relationship between dentists and laboratories, last thing here, tend to be less than ideal and often relatively short term. They bounce around, basically. Dentists bounce around from lab to lab because they're tired of hearing, I need you to take a new impression, doc. I need you to take a new impression. I sent that quote, or actually a screen capture, to Brad, the dental lab guy. And he sent back, and he said, that's because they never listen. Their ego gets in their way. Man. And I know Brad wouldn't care for me to say that because he wants dentistry to be better. And
when we know it's true, we know it's true. Brad's not just picking. I mean, it's unfortunately true.
That's a great segue, John, into our laboratory, the Dental Crafters Network.
Yeah.
And listen, here's the thing about the Dental Crafters Network is that they're not perfect, but they're awesome. You know why? Because I told them years ago when I first started using the Dental Crafters Network, before they were a sponsor, I was a user of the Dental Crafters Network. And you can bank on one thing. When we advertise people on this show, dude, they're vetted. Yeah. And if they ever give us problems, we're going to call them out. And if they ever give us problems or we give them problems, they're going to call us out. And that's what I want to bring up about the Dental Crafters Network tonight, John, is because how many labs will help you? And we want you to know that there are people at the Dental Crafters Network that are high quality, that can teach you quality, good impression techniques. Now, they'll tell you there are great materials out there that will give you maybe more precision, which is repeatability. But as far as an accuracy standpoint, what John was saying there earlier is that most impression material works. It comes down to one thing, is learn how to do it. And I'll never forget whenever a person from the Dental Crafters Network came to my office and was helping my new assistant that I hired last year take good, high-quality alginate impressions. And a couple things that I'd forgot, they actually brought up, and I was like, whoa. Like, dude, I forgot about that. And it really helped us as a team to be better. And so from a standpoint of, like, showing you techniques and how to do things, that's what I like about the Dental Crafters Network. I know we had one listener maybe last year, or maybe earlier this year, that said, I need somebody to bust my chops on my crown preps.
Yeah. Yep.
And let me just say right now, if you want somebody to bust your chops on your impressions, that's the Dental Crafters Network.
Yeah. They'll tell you if you want to know what you can do to become a better dentist, you need a partner that will call you out when you need it. And you need a partner who's trying to get better just like you are. And we look at the Dental Crafters Network as a relationship that comes down to making you better. You want to be a better dentist, you have to have a lab that's committed to being a better lab. We feel the Dental Crafters Network is right there. We've been through it with them. We've made them better. They've made us better. That's what relationships are built on. So if you don't have that type of relationship right now, you're looking for that, make that decision today to give them a call. And we want you to call them 1-800-472-8302 or go to dentalcrafters.net. Check out what they have to offer. Give them a call. Tell them the dental guys sent you. Give us some love so that they know that what we're doing on the show is actually working for them, because, this is important to us. You guys know, anybody that's listening to this show that's been sticking with us, you guys know what we're saying. So if you're looking for a lab that believes in the kind of things that we believe in, Dental Crafters Network is one to check out.
Yeah, I think it's great.
And I think that brings us right into talking about the product of the week, right?
Let's talk about techniques, man. Let's talk about our products of the week. So, John, let's talk about digital versus using materials for crown and bridge impression. Okay? Because both of us now are TrueDef users. I've been for a long time, but we still, even yet today, because of the limitations of digital, and we'll have another show on this.
Yeah.
There are some limitations to digital, but let's talk about just single unit crown and bridge, which we're doing every day. But if we're going to take a triple tray impression, the number one thing in this research article said that there was tissue over the finish line. John, talk about your tissue retraction method of choice with material, and then I want you to go into the digital version of that now.
Yeah.
So
what I've always done, and I know we've talked about this on the show before, so this is not going to be new to you that are longtime listeners, but we've talked about the tried and true method of retraction is the 2-chord technique, and it's very simple. You can Google it, look it up anywhere. And it's basically the idea that you prepare the crown, and as you break the contacts, you place a small cord. I used to use a 0 cord, and then I used a double 0 cord, and then I found out about a cord that I like the most now, and it's one that I heard about actually I think it was CRA that actually featured it on one of their little things on the back, where you see these random products that people like, and sometimes those things are good, sometimes they're not. but it's made by Premier, and it is called Knit Pack Plus, and it is a
You took
triple 0.0.
You took mine.
Oh,
I was pulling it up on the website, man.
Oh man, sorry. Well, there we go. So the 0.0 to me is something special because it is, no one else has this. It's very small and it is very, very tightly knit. So it doesn't unravel and it fits down into any sulcus, even the most narrow of sulcus. I use it when I'm doing class 5s, when I have good overall moisture control. You can slide it down that sulcus very, very easily. And this is a microfiber, so it doesn't really pick up moisture, which is interesting because some cords will kind of retain moisture.
Well, it's because of the way they knit that the surface tension of water will not break through the knit.
It's cool, man.
It's very cool.
And it cuts really well. It doesn't get stuck in burrs. Like, I really like Ultradent's Ultra Pack. It's great.
Yeah, used to use it for years.
But to me, this is better. And so I'm using that as my first cord, and then I'm using a number 2 cord if I have a big enough sulcus. That's probably 90% of the time, and then a 1 cord if I just don't have a big enough sulcus as my second cord. And that's what I've been doing for years. And Wes, yours similar, right? When it comes to if you are
if I was doing
a cord technique, that would be similar, right?
Same thing.
But you're doing things differently with you're not doing much cord stuff right now. Right?
No, the only time I do cord is if I'm dealing with situations where my connective tissue is an issue. So, pun. So we, in anterior cases, we use Knit Pack. One thing great about Knit Pack, by the way, is this little cutting mechanism that they have built into this thing.
Yeah.
Oh man,
cool.
It's next level. So you pull out the cord and you just close the cap and it cuts it for you. So it's awesome. By the time the thing wears out, you got a new cutter. And so you're not all the time having to sharpen your crown and bridge scissors, and like, man, the days whenever you're trying to cut.
Oh yeah, and you can't cut the cord.
Dadgummit, these scissors are not sharp. I'm tired of it. Yeah. You're yelling at your assistant. I told you to sharpen these. Get on the honing machine now.
That's right.
So anyway, I digress. So now I'm anteriors where I'm packing cord.
Yeah.
Or if I'm doing a class 5 and like the lower anterior and connective tissue is an issue, then I'll pack the Knit Pack. The Knit Pack from Premier is definitely our product of the week for people that are looking to take their impressions to the next level. Now, John, you and I are both digital impressors now. We capture our preps, at least most of our single unit preps, with digital imaging devices. Right now we're using the TrueDef by 3M, and I've been a COS user as well as a TrueDef user. I've also trained on CEREC 2D and 3D. And John, you've had your experience with TrueDef for the last 6 months. One thing that you kind of found out is that you needed to move to something a little bit more aggressive for.
Yeah,
and I haven't talked to you much about
since you
got
this definitely a whole other show about digital. My experience and transition from digital or from traditional impressions to digital. But the one thing that I found is, just to try to be quick about it, but the 2-cord technique still works great. Okay, it still works great for digital. However, anybody that goes digital and tells you that it is as easy to get impressions with the digital scanner, it's just not true. I mean, I'll just tell you straight up, it's not easy at first. You have to understand there's a difference, because if you have subgingival preps and you pack core down there and you inject VPS or polyether, whatever you do, you can get subgingival margins with ease without really having to think about it every single time. And so
what you're saying, John, is that whenever we talk about impressing, when we talk about the understanding material and how it works, it's called hydraulic and fluids, and how things move when they are fluid is they'll move around corners, they'll move into undercuts, but a digital scanner will not go down into and around a pocket. it has to
Right.
actually see it. It's a camera. I don't care how good your camera is. If you
Yep.
can't see the margin, then it
Yep.
won't show the
Right.
margin.
Right. So your retraction has to be better, and it has to be more. And now I will tell you, if I left a 2 cord technique and I left the cord in there for 10 minutes and left and went and checked hygiene, that'd be fine. And I looked at that. I kind of started playing with that, and I found that if I left it for longer, I could usually get it better. But the
Mm-hmm.
other thing too is you're on a time crunch
Yep.
because the scanner, you can't immediately, like with a typical high quality impression material, you take that cord out and your impression material is immediately there. So there's no chance for any kind of fluid. There's no chance for heme. Even if there's like the tiniest little bleeding, there's not even a chance for that to start because your impression material has already displaced that. Well, with your scanner, it's much harder to do that. You have to get, the couple teeth behind it as you're going down through your scan path. Usually it takes you a few seconds to get there. So there's more time there where the tissue can close back. There's time when things can seep. So for me, now I'm not saying everybody, because some people are better, I'm sure better than I am at this, but I found that I was wasting a lot of time, I felt, compared. I was much slower. And it wasn't just because I was slow at scanning, but it was because my retraction wasn't giving me as much as I needed. So I made the switch over, and I had to make a decision. And Wes is doing it one way, I'm doing it different. I had to make a decision between laser and electrosurgery. And this is the age-old debate, lasers versus electrosurgery. They're both good. Let's just cut to the chase. No one's going to say that lasers are bad or electrosurgery is bad. It's good. They're good for different things. There's good for different things. But when it comes to retraction in the posterior, I decided, for me, I have a bigger practice than, say, Wes, more ops, 2 doctors. It wasn't really cost effective for me to buy multiple lasers or really want to bring a laser from room to room. So I went with electrosurgery, and I got some high quality electrosurgery units, and I started troughing margins in posterior teeth. Very minimal troughing. We're not talking craziness, and not charring everything up to nothing. And it allowed me to get immediate impressions and have hemostasis that was lasting without having to worry as I'm scanning around. And it really helped me, especially when I was getting better at scanning, to not be held back by my retraction. Even now that I feel like I'm really good at scanning and I'm fast, very fast at scanning, I still really appreciate that. And Wes, a lot of that came from Wes. And he kind of told me, he kind of said, look, if you get a scanner, you might need to get a laser. He's like, I would definitely recommend looking at that because you're going to find that there's going to be certain things that you just can't do the same way because the scanner, like he said, can't see subgingival. So you got to have something that allows you to conservatively remove that little bit of difficulty from your field. Because again, I'm all for quality, but I don't have 10 extra minutes per crown prep to sit there on every case. And I know that I'm going to get, we know when you put retraction cord in, you have recession. Let's not act like retraction cord is kind to tissue. You have recession with retraction cord, and you also have maybe a slight bit of recession with electrosurgery or laser. Now, that's why I don't use it in the anterior, because I can't have that.
Well, that's why. Talking
a molar, though. I'm not concerned about 0.3, 0.4 millimeters of recession.
Yeah, that's where I'm at with this, is that I've been using a laser since 2004, 2005, a diode laser, and love it, love electrosurge, love TrueDepth scanning, love optical scanning, period. I think it's amazing. I think it's changed my practice. It's a practice changer for me. I think John is moving into what he has moved in, and we'll talk about this in another episode, into what helps him see dentistry, the way that we're moving dentistry, which is digitally, but that's a whole nother show. But yeah, you got to use something to get the tissue out of the way, whether it's nit pack or an electrosurge or whether it's a laser. You've got to get the tissue out of the way. You've got to do it right. I'll say one thing about scanners is that it takes all of the stuff that we talked about in this previous, and there's not been a study done on scanning because there's only 9% of all impressions received or all crown and bridge work sent to the dental lab, only 9% is optical scans. And so it's like, okay, there's not been a study on the quality of those. And so I would say that it would be higher because Brad, the dental lab guy, says that the remake rate on optical scans for his lab is 0.5%.
Yeah.
0.5%. So that means that it could make you a better dentist. I think it does because I think it's interesting to see your preps at about, on a 17-inch monitor,
Right.
and it's blown up and you can look at it in 3D and you're like, whoa,
Right.
I better do better. So
But I think there's a bias too, to be fair, that, the people who are going to invest in a scanner are usually, I think it's fair to say,
are good.
people that care and they want the best possible
Yeah,
advantages.
I agree.
that they
I
can
think
get.
you're
And
right.
so
I think
there's
the
some
early
selection
adopters in
bias.
these things is that I think that scanners probably are better dentists, just like dye trimmers are better dentists. Hey, you want to be a better dentist? Be a dye trimmer. You want to be a better dentist, learn good techniques.
Yeah.
And this has been a good show. From hey, let's get some crowns and let's get them on our endo teeth within 4 months. Okay.
Yeah.
And let's get some. Let's go to some CE or find somebody, a good technician that can teach you good quality impression techniques because it's more than just putting some stuff in a tray and shoving it in somebody's mouth.
That's right.
It's more than. It's more than. John, finish yourself.
Yeah. I think that it's been a great episode. Yes, we got some rant out of the way, but I think that, you guys know that we're going to call it like it is. That's one of the things, that's one of the reasons you listen to the dental guys is, you understand that really what it comes down to as far as good, why do you feel good at the end of the day? Why do you not feel good at the end of the day? Why do you have a good month, a good year? We feel, and we think it's proven pretty well that the best dentists tend to have the best businesses. It doesn't start the other way around. You got to have great business. It has nothing to do with your dentistry. We know you're listening to us because you maybe gotten sick of all the business stuff out there where people just they want to talk about money and business. We feel like it all comes down to good dentistry, doing things right, doing it well. Yes, learning how to do it quicker. And you come to us because we're providing that clinical side, that research-based side that you're not going to hear really anywhere else. And we know that there's an increasing need. We thank you guys for listening and you girls for listening to our show and for turning us into, it's kind of crazy, but is quickly becoming one of the most listened to dental podcasts in the country. We are really getting some very interesting things that are happening behind the scenes with companies that are getting interested in the dental guys, approaching us to try to get in on what we're doing because they see that we're doing things the right way and they want access to that. So we just would encourage you, keep listening. Number one, tell people about what we're doing and tell them to give us a listen. Engage with us on social media. Check us out. We've got our brand new logo and everything up on the website at this point. We've got ways you can connect with us on Twitter, on Facebook. Send us a message on Facebook. We reply very quickly to that. Give us some love on the Apple Podcast reviews. It's now Apple Podcasts instead of iTunes.
Yeah, it is, isn't it?
They changed it up. So get on Apple Podcasts, give us a review. That's how a lot of people find us when they're searching for dental podcasts. So if you give us a positive review on that, people are going to find us. Check us out at Voices Dentistry. Don't forget about that. This is, once again, a chance for us to connect with you because that's where we learn what you want more of on this show. It's been another great episode. And for Wes the Dental Guy, I'm John the Dental Guy. We are the Dental Guys.